Okay, hi, my name's Sophie Schofield. I'm a junior doctor based in southwest London, and I'm here to present another one of the sessions of preparing for the PSA series. The focus of this one being on the medicine and surgery side of the syllabus. Okay, so thank you for coming. I appreciate it's a dark, cold night, so I appreciate you guys giving me the time in the evening. Okay. As always, this session's sponsored by Wesleyan, and there's a lovely QR code if you're interested in more information. And this is the team that works very hard to put this together. We have Somaya, Balamrit, Janice, Akash, and the wonderful Dr. Sona, even. Dr. Sona, okay? These people work really hard, and this is all put together by Keele Medical Education Society and Mind the Bleep team. So we're really grateful to have you here tonight. Thank you for joining us. Okay. As with all these sessions, the Prescribing Safety Assessment series for Mind the Bleep has been created by junior doctors with a passion for teaching, and this is all done entirely on a voluntary basis. Okay. All we want to do is sort of teach from our experience and what we felt and what we experienced when we went through this ourselves, and help you feel more confident going into the exam. Lecture slides, teaching content are accurate to the best of our knowledge, and neither the tutors nor Mind the Bleep take any responsibility for any inaccuracies. And they have some wonderful T's and C's there if you're bored tonight, perhaps. So if you've been following the series, you'll have seen these previous sessions that have been quite thorough and it's sort of covering all the bases on the syllabus for this exam. And tonight we come to session 6, which is the medicine and surgery session. And this just gives a brief overview of what we're going to cover tonight, with a note that any sort of acute conditions have already been covered in the medical emergencies topic. You can also see that there are more sessions planned for the weeks ahead, so that you'll be in a good position come February. Okay, perfect. And again, this is the syllabus here. This is widely available on the PSA website, and I've just marked out here what exactly we're focusing on tonight. Okay, as you can see, there's a lot, but try not to be overwhelmed by it. If you take things in small bites, then it's always much easier to cover the material and feel good about going into this exam. Okay, so let's get going. So the structure of this session, I've split into both surgery and medicine. So the surgery, we can see the topics we're going to touch on here. I'm not going to read them out for you because we're going to go through them, but we will be covering all the sort of basic parts of a surgical syllabus that kind of come up in the PSA. The PSA is quite predictable almost. It has very recurring themes. So we felt that all these aspects are quite useful to cover, and they incorporate what's on the syllabus. And the same goes for medicine. Of course, both of these topics are very wide, big topics. So we are keeping within that little section of the syllabus that I pointed out earlier. Okay. So starting on surgery, first question, and I kindly, thanks to Sona, I have a little poll here that I'm going to throw up. Okay, let me know if there are any issues. Okay, so case 1, case presentation. A 44-year-old woman attends a pre-operative assessment for a scheduled laparoscopic cholecystectomy next week. She has a background of gallstones, hypertension, epilepsy, hypothyroidism, and anxiety. At the pre-operative assessment, she reports feeling systemically well. On examination, observations include a blood pressure of 133/82 and a heart rate of 65 beats per minute, regular. She's warm and well perfused, and she has heart sounds 1+2, no murmurs. And the question's asking you here to select the most appropriate decision option with regards to the clinical presentation and data. Okay, so if you guys want to take some time, have a little bit of time to look through this. I've had one response so far. Okay. And just a note to say, worked quite hard on these, and these are all questions that we've formulated from our experience. These haven't been lifted or altered from the mock papers. So everything here tonight is a fresh question. So hopefully that'll be of more use to you guys. Okay. Right. Okay. Right, I'll give you 10 more seconds, then I'll close this poll. Go on, be brave if you haven't. Okay, fine. So you can you guys see the answers in the chat okay? Does it show you who's voted for what in terms of percentage? It doesn't. Okay. Apologies, folks. 1 second. Okay, right. So let's go through the answer then. Okay, so question here is looking at medication that she's taken to remove a medication before the date, before a surgical procedure. Okay, so the answer here is omitting the losartan, 50 milligrams on the day of surgery. Okay, so what we have here is a phenytoin, an anti-epileptic, carbimazole, which is for her thyroid, her hypothyroidism, a diazepam, which is most likely used for her anxiety, and then amlodipine being another hypertension drug. Okay, so what's the reasoning behind this one? It's a difficult question, I think, because it's looking at omitting medications, it's looking at removing, and the answer here, basically what we're looking for is surgery and long-term medication. So I've kindly been informed that we're concentrating more on using Medicines Complete, which I think is a good idea. When I did my PSA, I focused solely on using Medicines Complete because it's much easier to look for information through, it's much easier to navigate through, and I think time is of the essence, particularly with this exam. So the section where you're looking to find this information comes under your surgery and long-term medication. Okay, the beauty of Medicines Complete compared to looking this up on the BNF is that you can sort of throw in surgery into the search bar, and this will come up quite high up on your options. Sometimes with the BNF, if you're not throwing in an exact phrase, you fail to get any results come up. Okay, so this is where you would find this information. But as I've said here, it's unclear, it's very text heavy, it's difficult to find that information quickly. And you'll find when you're in the exam that you've got the sort of the blinkers on, you're feeling a little bit anxious. And if you're looking for something, you want to find it quickly, clearly. And the last thing you want to do is be wading through thick text, okay? So my recommendation here is instead learn the medications that you should stop pre-operatively. As you can see here, I've shown you which ones should be continued, and I've also shown you which ones specifically should be stopped. Now, in my opinion, as with you all going through medical school, it's far easier to remember the smaller list or the things that you have to stop rather than both. Okay, so in particular, ACE inhibitors, all those drugs ending in pril. Okay, you've got your angiotensin receptor blockers, the ARTANs, the SARTANs, and you have your diuretics. Standard, as you'd expect, anticoagulants and antiplatelets should be stopped, but note here, there's some anaesthetist decision on this, okay? Pre-operatively, an anaesthetist will give yay or nay whether a medication should be stopped in that discussion, okay? What I would like to say as well is I think the PSA is quite a fair test in that they won't throw anything at you that's contentious or, you're umming and ahhing. They're not going to give you a question that's a pre-op and then they'll ask about warfarin and whether it stops or not. They make it quite clear-cut, to be fair to them, okay? So I'd expect it to be quite simple, quite straightforward, and no sort of murky areas or medications that aren't clear, okay? We've also got HRT and the combined oral contraceptive pill, which note that you stop 4 weeks before because it has that very procoagulant aspect to it, okay? We've got lithium as well and NSAIDs. So if you think about it, a lot of this makes sense. NSAIDs, anticoagulants, antiplatelets, medication like HRT and COCP that increase that risk of blood clots, or medication that causes too much bleeding, okay? And then it's worth knowing your ACE inhibitors and your ARBs are up there to be stopped before surgery. Okay? And I can see that 45% of you have said omit losartan. Good stuff, well done. Some people have gone for diazepam. And I think that's fair, because I presume what you're thinking is that sort of the sedating side of it before an anaesthetic. But actually, diazepam doesn't have to be stopped before an operation. Granted, it might not be recommended that you're on a high dose. If you're on that high dose, keep it. But like we said, we're keeping things very clear cut with this exam. Okay, and as far as the BNF is concerned, that's no problem. Okay, so let's move on. So next question, case 2. And let me start the poll on this. Okay, I'm afraid I'm a little bit slow with these things, so you have to bear with. Okay, so a 72-year-old man attends a pre-operative assessment. He has type 2 diabetes mellitus, which is managed with oral medications and diet. At the pre-operative assessment, he inquires into which medications he should take on the day of his surgery. On examination, blood glucose is 7.9, blood pressure 142/71, heart rate 72, heart sounds normal, no lower limb edema or peripheral neuropathy. And they're asking you to select the most appropriate decision option, considering the clinical presentation and data. Okay, so if you want a couple more seconds for this. We've got one answer so far, so if you guys want to be brave. Oh, go on. Okay, so one person's answered, and their answer, they went for omitting metformin OD on day of surgery. Okay? Oh, we've got a couple, apologies. So it's quite a contentious one here. Let me just close this poll. Okay, we've got quite mixed answers. Omit metformin on day of surgery, quite high. Omit sitagliptin, increase metformin. Okay, a bit of a hairy one. And I felt quite similarly, truth be told, when it came to diabetic medications. Okay, so, oh, sorry, folks. So the answer here is omitting the empagliflozin. Okay, horrible word, I think, in my opinion. Okay, on the day of surgery. So fundamentally, again, I'm sounding like a bit of a broken record at this point. What we want to do is remember, it's easy to remember the smaller list of things. Now, if you look at this table that's been put together from the BNF, okay, day before surgery, nearly all oral anti-hyperglycemics you take as normally. It's worthwhile remembering the ones you don't. And there's only 3 fundamentally. So metformin, you continue if they're taking it once or twice a day. But if they're taking it 3 times a day, on the day of surgery, you stop their lunchtime dose. Okay? Sulfonylureas, you omit the morning dose. And it's the same with the SGLT2 inhibitors, those gliflozin medications, you omit on the day of surgery. So I would only ever really remember these 3, truth be told. Okay, I think it's far easier to remember these 3 and then presume everything else is normal, okay, to keep it quick and easy to remember. Okay? Right. And as before, this is where you'd find the information if you were looking for the use of insulin during surgery. I must admit, BNF and Medicines Complete, not particularly great for finding this information. And I really think this table is your key to remembering any oral sort of type 2 diabetes medications quite easily. I think it's far easier than trying to rely on it in the exam. Information here on insulin use during surgery and any adjustments. But again, I think because it's a slightly contentious question, I think the PSA tends to be quite fair, and it sort of steers away from this stuff talking about a medication pre-surgery. Okay? So next question, and let me start that poll again. Oh, apologies, no poll for this one. Okay, give it a go yourselves. So a 72-year-old man attends to the pre-operative clinic for an anaesthetic review. He has a past medical history of myasthenia gravis and a drug history of prednisolone, 15 milligrams PO in the morning. Okay, and the anaesthetist considers his intraoperative steroid needs. So they're asking for one prescription or one drug that's most appropriate. What I've tried to do here is create it how it looks in the exam. I'm sure if you guys have done the mocks so far, you'll be familiar with this. They give you your name. I've written Jane Doe here, but if I was doing this exam, it would say prescriber Sophie Schofield, 7th of December 2022 at 1919, okay? So that'll all be filled in for you. All you need to say is the medicine, the dose, and the route. If you guys want to write any of this in the chat, you're more than welcome to, if I give you a couple more seconds. Okay, so what are our options here? So the question is quite targeted, in my opinion. It's asking you, it's pointing out that he's got myasthenia gravis, he's on prednisolone, and the anaesthetist is specifically looking at his intraoperative steroid needs. So we're not prescribing fluids, not prescribing anything else. What they're asking for here is a straight up steroid to be given. So when you come to look at it, you can look and find under sort of if you're looking for the steroids, the answer here is hydrocortisone. And I wanted to show here, the point I made here is that it's a replacement, and you've got two options here. When you pull up hydrocortisone, they're saying basically the difference between these two categories is whether it's a minor or a moderate or major surgery. I can appreciate how that's a bit panicking and you sort of sit there thinking, but if you look at the doses, the initial doses are exactly the same. So it's entirely irrelevant whether you go, say, 25, 30, 40, 50. In my opinion, it's easier to go with a set dose, and I normally went with the higher end. So if they said 50, I would say 50, but you'd also get a mark if you said 25 or anything between that, okay? I think it's easier to stick with what they've given you than start saying 31, okay? An unlikely dose. Keep it in increments that are clear, okay? And here I've just said, if you're looking for this information, and for example, here, this is adrenal insufficiency, but all this information is found quite easily on Medicines Complete purely by just sort of, if you type in steroid or steroid treatment, surgery, as you can see the previous searches, okay? And then you get the information up front quite easily, and you're good to go. Like I said, it's the time pressure of this exam that makes it painful, okay? So my little tip to break this up, you can't do enough questions. The more you do, the better you feel, and then you know you're going much more quickly. And you also identify patterns, so the more you do, the better. Okay, and Control and F. I'm sure you've heard this 100 times, but the more familiar and the more comfortable you come with Control and F, the information really speeds you up and you feel so much better at the end. Okay, so next question. A 21-year-old woman is to undergo an elective explorative laparotomy for endometriosis. The anaesthetist decides to induce her with fentanyl. She weighs 70 kilograms. During the procedure, she suffers muscle rigidity, fevers, and seizures, and she is felt to be suffering serotonin syndrome. Select the one drug most likely to cause this adverse event. And we have 5 options there. So let me give you a couple of seconds to answer. Okay, so shall we have a look? So the answer here is St. John's wort capsule, okay? A bit of a hairy question, I feel, okay? It feels a little bit overwhelming when you first see it and you think, God, fentanyl, all these different drugs, I'm not sure. So what are we looking for here? So what we're looking for here is the interactions section of Medicines Complete, okay? Medicines Complete is cracking for finding a good interaction. If you search fentanyl, you can also write fentanyl and St. John's wort and morphine and bisoprolol and amoxicillin and ketamine, and it will show you it'll come up and show whether these drugs interact together. Okay, it's really clever and it's really efficient. So when you come across an interaction question, medicine's complete, copy and paste them all in, add and between them all, and you can be so speedy with this if you're a little bit more tech savvy than me. And then it very quickly shows you interactions and then severity if there's more than one interaction. Okay, so if we look at fentanyl and St. John's wort, we can see here that it increases the risk of serotonin syndrome. Okay, case 5, 32-year-old lady is in labour with a baby in breech. The decision is made for a caesarean section. Anaesthetist draws up an antibiotic before the procedure starts, and they're asking you to write a prescription for one drug that's most appropriate to prescribe accurately. We're looking for medicine, dose, and route here. Okay, if anyone's feeling brave and wants to throw it in the chat, I'd respect you a lot. Okay. Okay. Well done, Alicia. Good to be brave and put it out there. Okay, a couple more seconds. Okay, let's have a look. So what we're being asked here is we're being asked for an antibiotic before a procedure. So it's a prophylactic antibiotic. And the answer here is, as Akil said, and you were close, Alicia, it's similar sort of category. It's cefuroxime, cefuroxime, butchering the pronunciation beautifully. Okay, and this comes under surgical prophylaxis. Okay, now it's a really difficult question because you sort of see it, and again, there's a bit of panic. Where do I find this information? Where is it? Okay, so the answer here, 1.5 grams, initially by IV injection. Now, if you're ever wondering about dose or route, think about it in a context. If you had a lady who's about to go for an emergency C-section, are you going to give this by mouth? Chances are not. It's far easier to pop this in a vein. Okay, so where do you find this information? So this is my love of treatment summaries. Okay, this comes under antibacterials use for prophylaxis, and there's a specific section that's obstetric and gynecological surgery. And then you look into C-section, and here you are. It takes you to the antibiotic you want, and then you click on it and find your dose. The beauty of Medicine's Complete again is that you can type in quite vague terms, and sooner or later you get yourself there. So I think, and don't quote me, but you can type in caesarean section or or prophylaxis, and sooner or later you'll find yourself on the antibacterials use for prophylaxis page, and then you can go into your specifics. Okay, quite a good but easy question to ask. Okay, really makes you look for the answer. So, case 6, a 33-year-old man is admitted to the surgical ward awaiting a laparoscopic procedure for cholecystitis. He's nil by mouth until the procedure, and his weight is 76.5 kilograms. And we're asking for a prescription for one IV fluid that's the most appropriate for the patient at this stage. And here we're looking for fluid, volume, and duration. You don't actually have to work out the infusion rate when you do the PSA. It calculates it for you. Okay? So if you want to take a minute, guys, and again, if anyone is brave enough, lots of kudos your way. Okay, so let's have a look then. Okay, so the answers here possible, quite a few. Okay, and the idea is that you need to acknowledge that what we're prescribing for this chap, so he's awaiting surgery, he's nil by mouth, and we have no information that he's unwell or that he's losing fluids. So what we're doing here is we're prescribing for maintenance. We're trying to give this man fluids to make up for the fluids that he's not taking in naturally because he's not eating and drinking, but he's not actively losing fluids and he's not unwell. Okay, so as I said here, we need to recognise he's not getting these fluids from eating and drinking. He's not acutely unwell, so he doesn't need resuscitation fluids. And we're not talking about fluid loss. It's quite a straightforward fluid question here in the sense that we're not asking for replacement fluids. What I wanted to do with this question is show you the beauty of the PSA is the range of answers that you can give. So we have sodium chloride with potassium, and you could give either. You could give 40 millimoles or 20 millimoles. Okay, we're asking for one fluid, one bag to give to start this chap with maintenance fluids. Okay, alternatively, you could look at glucose, and perhaps if you were feeling very brave, you might do glucose and potassium. I think my suggestion here is keep it simple, keep it easy. You've got enough going on. You don't get extra marks for making it particularly exciting. So just stick with a bag of sodium chloride with some potassium. Okay, the key as well is to note that this is how old is this chap? This is a 33-year-old man, so he's a young man. We've got his weight, and he can take a litre of fluid, probably over 8 hours. If he was an elderly man, I might give it to him slower. But the key with the PSA, again, is that they let you have it within ranges. And 8 to 12 hours, any number of hours between that is perfectly acceptable, okay? So don't get caught up on the small details. Just give sensible, logical answers. Okay, and then just a note on fluids here. Okay, all right. Plasma-like Hartmann's, yeah, these are all fine. I've just given some answers. This is the point I'm trying to make, that there are lots of possible answers here. It's just got to be a reasonable, logical answer. As long as you're not giving 500 mils of sodium chloride in less than 15 minutes, most answers are fine. Hartmann's is fine. That's a nice balanced one. Plasma-light, I mean, you can say it, but this is what I'm saying about keep it simple for yourself. Go for an easy answer. Plasma-light's used quite rarely, actually, in practice. And also, they don't let you put in brand names into the PSA. So I would honestly stick to sodium chloride or glucose. You could say Hartmann's, but I think that comes up. It doesn't come up as Hartmann's in the PSA, if I remember rightly. Okay, right. Just conscious of time here, folks, so I'll crack on. So just a touch on fluids. BNF medicine's I found completely useless for this sort of thing. So again, understand it, know it, and you can apply it. And it's far quicker to understand and apply the knowledge than to try and scrabble and look for it during the exam. So if adults need 25 to 30 millilitres per kilogram a day of water and 1 millimole of electrolyte, being sodium or potassium, you need to acknowledge it's 50 to 100 grams per day of glucose. Okay, so if we've got an 85-year-old kilogram chap, he needs 2,550 millilitres of water a day, 80 millimoles of sodium, 80 millimoles of potassium, and between 50 and 100 grams of glucose a day. And this is an easy way that you could deliver that fluid requirement in a day. You could give 1 salty and 2 sweet bags over the day, 2 lots of potassium split between the 2 bags, acknowledging that you can't give more than 10 millimoles of potassium an hour. So it would have to be over at least 4 hours. And as we said here, this is a maintenance fluid, so we can take our time. We can do it in 8 to 12 hours. Okay? So understand your maintenance fluids, feel confident in doing them, and then that's quite a few of the fluid questions that are coming your way in the PSA. Okay? And I'm just looking at fluids purely from a surgical perspective for this section. Okay? There's a more in-depth analysis of fluids in another session. Okay. Perfect. Dr. Sohn has very kindly thrown in further information there, so I will crack on. So another thing worth acknowledging in the surgical section is post-operative analgesia. Okay, I'm sure you're all very familiar with the WHO ladder of pain, or WHO pain ladder. Okay, and the idea that you start with mild pain and you medicate as appropriate considering the degree of pain and what they've had before. okay, and increasing the medication you give the analgesia depending on the strength of pain, okay? And examples, what I'm getting at here is the ability to acknowledge the level of pain and then prescribe something appropriately. If someone's had something post-operative, then morphine is reasonable. If someone's come in because they've sprained their ankle, you might suggest that they start on an ibuprofen, okay? So, case 7, a 38-year-old man is admitted to surgical ward with acute pancreatitis. He has developed sepsis. He has a past medical history of type 2 diabetes, a drug history shown in the table. And his observations are a blood pressure of 130/82, a heart rate of 80 beats per minute, regular, and normal heart sounds with no murmur. And they're asking you to select 2 medications that are the most likely to have increased his risk of pancreatitis. Okay, and we have the medications all on the side. So let me... go for it. If anyone wants to be brave again and say in the chat, I have maximum respect for you. Okay. Are you going to be brave, Luciana, and throw another one in? Very good, okay. Kudos. Okay. A couple more seconds. Okay, folks, should we have a look? So kudos for putting answers in. Yourself too, Princess. Well done. Okay, so the answer here is allogliptin and dulaglutide. Okay, so Luciana, well done. Alarmingly speedy answers as well, Luciana. So impressive stuff. Well done, Princess, too, for throwing your name in the hat as well. Okay, so questions asking which 2 drugs put him at risk of pancreatitis. Okay, so this comes back to our side effects. So this question is specifically asking side effects, pancreatitis. Okay, now I don't think there's any clear way of doing this effectively. In my opinion, I'd look at the drugs and I'm acknowledging that some of them are diabetic drugs. So we have metformin, we have the allogliptin, the dulaglutide. These are all diabetic drugs. So if I was time pressured and trying to make my way through this exam with some speed, I would look at those 3 first, knowing that they're anti-diabetic, there's insulin, we're talking pancreas. That would be my vague sort of thinking. But I think it's worth having a look at them all if you have the time. Okay, if you look up the first 2 and you see pancreatitis, hurrah, we've got the answer, we move on. But you can look them up, and there's no greatly effective way of doing this other than Googling, not Googling, what am I on about? Medicine completing the drugs. Medicine completing the drugs, and then Control F, and I'd write pancreatitis or pancre and see what came up. If nothing came up, then I'd move on to the next drug. Just looking at the questions here. How do we know this is not an interaction question as I looked on Medicines Complete? Well, so it's not an interaction question because we're not asking for which 2 drugs are interacting with each other. They're saying which 2 medications are most likely to have increased his risk. So we're not asking what's interacted. It's more about what's increasing a risk. I can see how you'd think that, but I think you'll also find that if you look at the interactions between all these drugs, none of them will interact to cause pancreatitis. So I imagine you'd probably draw a bit of a blank on that one. And Luciana, just recall, well, that's kudos. I'm not sure I could do that. Okay, so let's crack on. So we've whistle-stop toward surgery. Let's look at our medicine topics. Okay, and we start with case 8. Okay, 84-year-old man is admitted to care of the elderly ward with an acute exacerbation of heart failure and a community-acquired pneumonia. He's noted to have an AKI stage 1 on admission. Past medical history is heart failure, type 2 diabetes mellitus, and rheumatoid arthritis. His current medications are listed in the table. Okay, question A asks to select 2 prescriptions that contain a serious dosing error, and question B asks to select 1 prescription that contains a frequency error. Okay, so have a go, see what you can do. If anyone, again, is brave enough to throw their answer in the chat, you'll get maximum respect. And when you do this in the PSA, there'll be 2 separate columns, one for question A and one for question B. So you have the same question, all the same answers, and you answer both questions on the same sort of computer screen page. Okay. The reason I did it like this was because I used to find these quite overwhelming because it looked like a lot of information that you had to trawl through. So if you can get used to it. Okay, good stuff, Sophie. Okay, I'm going to crack on. I hope you're all sort of brewing it over at home. So for question A, is asking for 2 prescriptions that contain a serious dosing error. And Sophie, you're on the money. Well done. Methotrexate, 75 milligrams once weekly. So Sophie, what's the correct dose? Are you willing to say? Okay, so I'll say, yes, perfect, well done. 7.5 milligrams, okay? So I used to find they were quite sneaky about where their sort of decimal point fell. And you might look at something as you're speeding through it and not acknowledge that it's 75, not 7.5. Methotrexate is a powerful drug. 75, I think, would probably knock you out for a while, okay? And then we've got sitagliptin, 100 micrograms, okay? So, apologies, folks. I've frozen for a moment. Okay, does anyone know the dosing error with sitagliptin? There, well done, folks. So it's a unit issue there. Well done, really nicely done. Which brings us on to question B, okay? Frequency error. And the answer here being doxycycline, 200 milligrams BD. Okay, I think it's exceptionally sneaky when I did this. I was very proud of myself. Okay, so doxycycline, 200 milligrams OD. And it's an odd regime, doxycycline, because you do 200 milligrams OD and then 100 milligrams OD for the 24 hours after. Okay, but it's never BD. So even if you were sort of sat there thinking, well, it says it's 200 milligrams and 100 milligrams, is that right? Well, both are correct doses, but it's the frequency there that we're looking at, okay? These questions are hugely time-consuming, and I think, you earn more, you score more points by doing them than some of the other. So I'd give myself a little bit more time to do these, as there's more per question. But well done, folks. Really nicely done. Okay, so case 9, 33-year-old man attends your GP, complains of a retrosternal burning after eating spicy foods that's often worse at night, and bloating. Past medical history none, drug history none, weight 100 kilograms. And we're looking for a prescription of 1 drug that's the most appropriate to prescribe acutely. Okay, folks, so I'm going to throw it to you in the chat again. I want a medicine, I want a dose, and I want a route. Okay. Is anyone going to be brave enough? Very nice. Well done. Well done, Nidhi. Well done, Luciana. Good. So what I was getting at here is the idea of dyspepsia. Okay, so dyspepsia, as it says here, the sort of GI, acid refluxy symptoms, gastric reflux, bloating, nausea. And I suppose the hints here are he's got no past medical history, so this isn't like an unusual myocardial infarction. He takes no drugs. He's been eating spicy foods, and he is 100 kilograms. He's quite a sizable chap. Okay, so dyspepsia and the initial management of uninvestigated dyspepsia is a proton pump inhibitor taken for 4 weeks. Now, I'll apologise because the frequency and duration that I've made on this question didn't quite fit with 4 weeks, but on the whole, as long as we're looking at a PPI, as some of you have suggested, we're on the right track. And look, there are lots of options here. It purely has to be a proton pump inhibitor. As I said before, you don't get marks for being particularly exciting. So make your life easy and go with omeprazole, go with lansoprazole, okay? Dosing has to be correct, and 20 milligrams both by Nidhi and Luciana were cracking. So you get the marks, OD, PO, perfect. Okay, so you're going to score the same number of marks as long as it's in the right class. And you're not asked to give a frequency of time over which the drug should be taken, so you don't need to be worrying about the up to 4 weeks part of that section. Well done, folks, really good. So case 10. 27-year-old woman attends the emergency department with shortness of breath after arriving home after a long flight. Past medical history, none. Drug history, the combined oral contraceptive pill. No allergies. Her sats are 98% on a 15-litre non-rebreather mask with air entry reduced on the left side. She's diagnosed with pulmonary embolism of a CT pulmonary angiogram. She's not pregnant, and nothing particularly exciting in her U's and E's, okay? And you're asked to prescribe one drug that's most appropriate to prescribe acutely. Medicine, dose, and route. Okay, and if anyone's brave again, you gain respect. Okay. Anyone fancy it, having a go? Okay. Should we have a look at the answers? So, answer here, apixaban or rivaroxaban. So well done, Catherine's and Monica and Princess. Well done. Everyone's there, cracking. So the point I'm trying to get at here on this slide is that this comes under venous thromboembolism. And again, this is a little tick towards Medicines Complete over BNF, in that if you write pulmonary embolism, DVT into Medicines Complete, you find this information far more easily than you would if you put this into BNF. BNF can be quite obtuse about finding things and make things difficult. So well done, really nicely done. So apixaban or rivaroxaban with patients in a confirmed proximal DVT and PE. And note in the question, you were told it's a PE, you're given all those lovely common signs, long haul flight, combined oral contraceptive pill, young woman. Yes, it is Nidhi. That's absolutely fine. And I'm sorry, it's my slightly poor answer of the when I made that slide. To be honest, I imagine in this question you get it if you say stat dose or for 5 days. I'm afraid that's a hole in my that's feedback from my presentation slide making, but you'd be 100% right. Okay, so apixaban, rivaroxaban, easy answers. Go with it. Make your life straightforward is what I'd recommend. And Sona's very kindly thrown that in there. Perfect. Okay, so apixaban 10 milligram BDPO for 7 days. There we go, Nidhi. 7 days, far better answer than the one I had up there for once only. Or rivaroxaban, as said by Princess. Okay, be careful when you're going through the VTE prophylaxis document to pick between treatment doses and not prophylactic even. So you're not giving someone medication in case they get it. You're treating one that's already there. Okay. And it sounds like a silly thing to say, but in the blur of the moment and the panic of doing the exam, it's so easy to pick up one and then kick yourself later. Okay. You can also sort of look at this guidance for thromboprophylaxis, as I mentioned, and it's worth noting that it's all in the same treatment summary. Okay, they've thrown it all under venous thromboembolism, but it's split into surgical and medical patients. So if you're being asked to prescribe something for thromboprophylaxis, make sure you keep a real eye on whether it's a medical patient you're writing this up for or a surgical patient. Okay. And then just to touch here on enzyme inducers, as I said, worth remembering some of these just to speed up, answering of questions. This information can be found, but if you can make your life easier and if you know it, then you don't have to look it up, and that certainly wins a few seconds over for yourself. So the idea is that an inducer reduces the concentration of a drug metabolized, and the way I remember this was through scrap GP. Okay. There are other slightly more spicy of ways of remembering it, but I think this is the best, most wholesome way. If we're talking about inducers, we can't forget the inhibitors. And again, these inhibitors increase concentration of drug metabolized. So if it inhibits it, it increases that concentration. Okay? So again, a good way to remember this, I go with sick faces. So, case 11, 77-year-old lady is scheduled for an endoscopic procedure and is to be kept nil by mouth. She has a past medical history of duodenal ulcers and osteoporosis, a drug history of vitamin D and omeprazole. Her weight's 46 kilograms, and she complains of some abdominal pain, which she scores as 3 out of 10. So, they're asking you here to write a prescription for one drug that is most appropriate to prescribe acutely. Okay? So consider what we said earlier. And again, if anyone is brave enough to throw a suggestion in the chat, it would be very welcome. Okay, let's have a look. Anyone willing? I'll give you a couple more seconds. Okay. Fair suggestion, Princess. So, the answer I was looking for here, and perhaps it's a little bit too vague, the question format, is that she's complaining of abdominal pain, which she's scoring as 3 out of 10. So what I'm looking for here is one drug that's most appropriate to prescribe for that pain. So apologies, Princess, if I didn't make that slightly more clear. So we're looking for an analgesic that can be prescribed for a low pain, a very mild pain, for a lady who's nil by mouth. No, don't be sorry. Entirely my fault. It's really good to get this feedback, actually, and I can see it from how you guys are viewing it. Okay? That's fair, Princess. So paracetamol, great answer. And Monica, IV paracetamol, great. Okay, Catherine, 500 milligrams. How are you giving that, Catherine? Okay, so perfect. Clearly, I need to clarify that on the question better. Okay, well done, Catherine. So she is nil by mouth. She weighs 46 kilograms. And we're looking for something for pain here. So you're right. You guys have you're climbing that analgesic ladder beautifully. And you've acknowledged that paracetamol is the first rung. So thinking back to pain ladder, very mild pain. And also look at her history. They're talking about duodenal ulcers, and she's to have an endoscopic procedure. Probably something to do with the ulcers, I think. Okay, so she's to have a history of ulcers, so we want to avoid any NSAIDs, any ibuprofen, any of those sort of aggressive stomach lining disliking drugs. Okay, paracetamol is appropriate to prescribe here for pain. And as you guys noted, and I think Princess has said a few times, as she's nil by mouth, it needs to be an IV dose. Okay, the point I'm getting at here is that when you're dosing someone via IV rather than by mouth, you have to acknowledge body weight. It's a sneaky one because she's 46, so she's under 50. And if you look here on the indication, it's 15 milligrams per kilogram every 4 to 6 hours for someone who's up to 50 kilograms. So if she's 46, we're looking at 46 times 15 milligrams. And you get 690 milligrams would be the dosage of IV paracetamol. Okay, well done, folks. Okay, case 12. 64-year-old man presents with cough, shortness of breath and fevers. He explains he's been producing green phlegm for the last week and relying on his blue inhaler more. Okay, past medical history, COPD and type 2 diabetes mellitus, and a drug history of salbutamol and ipratropium. And on examination, you hear left-sided crepitations and note that he has a temperature of 38 degrees Celsius. Okay, in terms of treatment, he's already been started on nebulized salbutamol. So the question is asking you to select the most appropriate management option at this stage. And Sonia's very kindly thrown up a poll there. Okay, so take some time, folks. Okay, anyone else willing to be brave? Okay, fab. So what we're looking at here is an exacerbation of COPD. Okay, and the answer here being starting prednisolone 30 milligrams OD. Okay, so where are we finding this? So this is a COPD, chronic obstructive pulmonary disease. Okay, the treatment summary. And if you read through it, it very quickly suggests a course of prednisolone after a salbutamol or nebulizers have been provided. Okay, if you click on prednisolone, it very quickly gets you to the dose. It comes up quite often, so it's worth remembering 30 milligrams, 5-day course, PO. Okay, well done, folks. I'm just conscious of time here, so I'm going to whip through this one. 83-year-old woman presents to A&E with shortness of breath, past medical history of ischemic heart disease, hypercholesteremia, a previous STEMI, and type 2 diabetes mellitus. Okay. Drug history of bisoprolol, lisinopril, clopidogrel, ticagrelor, and atorvastatin. On examination, she's saturations of 89% on 15 litres non-rebreather mask, a rest rate of 41 breaths per minute, bilateral crackles, and considerable pitting edema to the mid-shin bilaterally. Okay, I've thrown in a chest x-ray here, as sometimes they'll give you an image. Okay, select the most appropriate management option at this stage. Okay. Okay, you guys are speeding through this one, and you're all going for the same thing. So well done. Okay, it's a straightforward, relatively straightforward by final year, I think, here. Okay, so an 83-year-old woman presents to A&E, and the first thing we're going to do is a furosemide 50 milligram IV stat dose. Okay, so this lady has a cardiac failure and pulmonary edema. Okay, now I'm pointing at the cardiac failure through that ischemic heart disease, hypercholesteremia, and a previous STEMI. She's got a heart that's received some damage and is now working harder. And the chest x-ray shows some considerable pleural edemas. Okay, and well done. Perfect. Furosemide 50 milligrams IV stat. Okay, well done, folks. And again, this is where we find this information. It's all under sort of chronic heart failure. If you look through it, diuretics are recommended to relieve breathlessness and edema in patients with fluid retention. Furosemide, you have other options you could prescribe as well, but a furosemide's your go-to. Okay, it's an easy one to answer, same as if you were writing this for prescription. Okay, and that's all then tonight, folks. I'm sorry I sped up a little bit at the end. I'm conscious of your time and not wanting to take more of it than you've already kindly given. Next session is on the 15th in 5 days' time by two brilliant doctors. Can't recommend enough. And I've got a QR code for feedback here. It takes a lot of time to make these presentations. I hope you found them useful. I would be incredibly grateful if you could kindly throw me some feedback so that I can make these presentations more useful or more catered to what you guys need.